So a lot of what we're going to talk about today is getting really down into the emotional aspect, not just for our patients with eating disorders, but also having to consider our own emotional experiences when we're working with people struggling with eating disorders. So we're hoping in the next couple of hours that Christy and I are able to not only help you get more in touch with your own feelings and how you work through those, but mainly how you can coach our patients when they're admitted to being able to manage their difficult emotional experiences while they're in here. So it helps them heal, the ultimate goal. So our outline is what we want to cover here mainly is looking at how eating disorder patients impact your experience as a professional and your own practice. We want to look at therapeutic alliance. Dr. Olaby's already talked about that to some extent. So basically the professional, your relationship with the patient, what that looks like. And what about boundaries? We know that this is an incredibly serious illness with a lot of risks associated with it. And so we know that boundaries also have to be set with these patients, right? Everything is not going to go exactly to maybe how they want it to go. We have to have certain limitations, but we have to kind of enforce those in a certain way, right? So there are non-negotiables. And so we also know that emotions run very high, not just for our patients, but for us too. And so we want to look at just some basic information and education around emotions, emotion in the brain, and how do we calm ourselves and our patients when that tidal wave is at its peak. And just having an opportunity for lots of questions and answers hopefully too. So again, we're like Dr. Olaby, please bring them to us when you think of them and as we go along, okay? Because then we can kind of deal with that in a moment. Okay. Anything else for Steve? Yeah. So just asking it, putting it out to you guys, what's it like when you hear that an eating disorder patient is coming to your unit and you're going to be really involved in caring for that person? Just throw out some thoughts that just come to your mind right away.
Fear.
Fear? Okay, so the emotion of fear.
Unprepared.
Okay. Sorry?
Unprepared.
Unprepared.
Ill-prepared.
Okay.
Stressed.
Stressed. Yeah.
I'm more excited for the opportunity to help.
Ah. Okay, so maybe appreciating a bit of the challenge and learning that goes along with it. And all of those feelings are really quite, you get a combination of feelings when you're dealing with these folks, and not always comfortable ones, right? But also that anticipation, which is kind of neat for me to hear, that there's people that actually look forward to this too. But the fear, the stress, the worry, am I going to be able to handle this? It's all normal, right? I get that too, and I've been working with these folks for like 20 years. It just depends on the situation, so that's very, very common. It's understood, and we get, right, that's going through your minds and all your feelings and your bodies for when they come in. So it's complex, isn't it? And so it's normal, right, to have all these different feelings. Look at us. They all apply. I like the baby in particular.
Yeah. We don't have a one-to-one.
Not going to. So Dr. Olaby talked about this to some extent too, or to a great extent, and explained this very well. But which of these would you say causes eating disorders?
All of them.
Interesting, right? There's no actual known singular cause for eating disorders. However, we do know that there's a genetic predisposition that exists, right? But there's also these other things that I wouldn't say cause necessarily, but they influence. They can influence the development of an eating disorder. So temperament, we look at just the nature of somebody's being, their personality, their characteristics. And in puberty, we notice that a lot of diagnosis of the eating disorders, like you mentioned, Dr. Willoughby, too, but we're looking at about between the ages of 15 to 19, so that just after puberty, there's a lot of people being diagnosed.
It's really important, just for your own information though, it's absolutely shocking that we are seeing children being admitted and diagnosed every year now. And that it is very common for girls in particular, but also boys, to think that they're fat as early as the age of 10. Mm-hmm. Really, really common that 60%, 70% of young girls think that they're fat when only 10% of them might be overweight. Right? So it's in there, it's out there. And kids are just trying to be like teenagers and not eat.
And there's also thanks, Christy, there's also been some research or some stats out there that young children have said that they're more afraid of getting fat than something happening to their parents or of getting cancer. So there's a huge, huge fear. We have to consider coping style when we look at risk factors. We need to look at, like you said, Dr. Willoughby, life stressors. And we also have to look at family factors. So when we look at this, which of these do you think we have some ability to change?
Coping style.
Yeah.
Some stressors. And the
family.
Yeah. So mainly the family factors, coping style, because we're always going to have stressors, right? And so how they learn to cope with them is very, very important. And so knowing that we can influence family factors and coping style, this is where another approach comes into play, and this is what we're going to incorporate a lot into our talk with you guys today, and our even our role playing and things like that. Not to freak you out, but a little bit of role playing. Is with an approach called emotion-focused family therapy, EFFT. And so that one is looking at, Christy and I work a lot with parents about how do you learn to, we teach parents how to be emotion coaches for their children. And our goal, hopefully today, is to give you some of that as well, that knowledge and that skill, so that you can help patients and you can sort of be a teacher in terms of them being able to manage their emotions more effectively as well. Okay? So we're teaching you part of the EFFT approach today. That's our goal. Our belief, our underlying belief about eating disorders, it's absolutely not their fault. And it is not their parents' fault either, their caregivers' faults. I think that historically there was some blame that used to be put on to parents, used to be put on to the person themselves. And we're just seeing that as not true. It's not helpful either. Ultimately, however, there is a responsibility of the person with the eating disorder and their caregivers in terms of managing the illness and recovering from it. Okay? So we're not blaming them for its existence, but there is a responsibility for them to help with recovery. So we're looking at caregivers taking charge, especially when somebody's in denial of having the eating disorder. And the environment we create does have influence on the experience of eating and recovery. So that's not just the home environment, that's the hospital environment. So we'll look at this old Virginia Satir diagram. So the eating disorder is a bit like an iceberg, right? We just see typically what's on top, you know, so we notice things like restriction, binge eating, over-exercise, purging, a preoccupation about food, weight, body shape, and size. We might notice that there's a lot of fear and guilt and shame, those kinds of feelings. But we know that there's so much underneath that. You can't just say to somebody, well, just, you know, improve your eating, get over it, you know? There's so much there that's going on underneath. So like Dr. Olaby mentioned, I won't go through all of these because I don't, you know, in the sake of time, but things like bullying, teasing, history of trauma, unmet emotional needs, so never feeling good enough perhaps, lacking sense of self or identity, notice that a lot, personality tendencies, as he mentioned as well, perfectionism, fear of making mistakes, high sensitivity to emotions of others, and pleasing others, see that a lot too. Societal and cultural influences, peer pressure, you look at social media, huge today as well.
Especially in the younger population.
Constantly on phones, right? Yeah. And coping skill deficits, so not able to manage emotions very well. And this is really important. Displacing, so their feelings about how they're doing in life onto their body. And you mentioned that too, Dr. Olaby. So they might be struggling in life, and this is something I can do about it. And this is also something that's culturally accepted and promoted, unfortunately, is a lot of weight loss. And you'll feel better about yourself. This is the answer, man. This is the way to go. And I mean, we can, I don't know about you guys, but if we look, you know, into some of our past, has anybody ever experienced that, right? It's very common. You hear people wanting to diet, to lose weight. It's very common in our society, so to feel better about ourselves, right? So, also below the surface of eating disorders, we look at mood disturbance. I find this neurochemical piece very interesting, that oftentimes what they've done is, in some research, is looked at the level of serotonin in people with anorexia nervosa, and that sometimes those levels seem to be very high. And so what they find is that people, when they go into starvation mode, they end up not getting as much tryptophan, which is an amino acid that helps produce serotonin. So if they have less of that going into their bodies, then their serotonin level can decrease, and so can their level of anxiety. So for people, oftentimes they're restricting it, and it's being reinforced. They're feeling more calm. I know Mandy's got this weird look, and I was like, really? And it was really interesting for me to look at this research as well. And I don't know how far this will go, but I did find it very interesting. So that it makes sense that when people are being fed again, we know that eventually their anxiety can dissipate and get better. But it could be that when people are refeeding as well, that's a really high anxiety state for a while, because they're getting more tryptophan through the food and the serotonin's going up, and they're not used to their serotonin level being up. Just very interesting, I think. The other thing that comes to mind too is there's a portion of the brain called the insula, and this is another piece that I found very interesting. When they've done some research, they've looked and seen that there seems to be less blood flow going through that area of the brain with people with anorexia. And this particular area of the brain seems to have a lot of responsibility to send messages between the brain and the body. And so what they're looking at, is there a connection then between this area of the brain and body image distortion? Because those connections might not be made very well. I don't know. What do you guys think of that? I just thought it was kind of interesting. Yeah. It helps me maybe have a better sense of why this is so hard for patients, you know, when they're trying to be retrained. Okay. Any questions so far? So again, all these things come up for the patient as well, right?
Yeah, so patients with anorexia and patients with bulimia, they're in the hospital for symptom interruption or refeeding, and they're terrified, right? So if you can imagine your own emotions, what else do you think might be coming up for them besides just straightforward anxiety, fear, things like that? Maybe you've been involuntarily committed. Maybe your parents have dragged you there. What else do you think might be going on for them? Yeah, they might just be really pissed off. And remember, many of these clients or patients do not have insight that anything's wrong. And they're really mad that people are forcing them to do something that they don't want to do. Because remember, this anorexia is really working for them. They don't have to feel anxious, they're feeling in control, they don't need to focus on anything else that's bugging them, and you're telling them, you can't do that anymore. And by the way, eat this. Right? So when you do that, there's a spike in anxiety. They go right into fight or flight. And when you think about it, there's a terrified animal in the corner, and you're going, here, eat this. And they'll come out the, right? So they can exhibit some pretty strong behaviors, some very devious and manipulative behaviors. And it's all fueled, for the most part, with very basic emotions relating to fear, anger, frustration, and things like that. Yeah, so fear of judgment. Sometimes they feel very guilty and ashamed because these are people that they're resorting to these disorders and behaviors because they do not feel very good about themselves. And for some of them, their self-worth is so low, they even feel guilty for taking up space. They don't feel like they deserve help, and they really dislike being so visible and under the microscope. And of course, there's that anxiety that we've talked about, schedules, having to eat at prescribed time. You know, their disorder is all about control, and we've just taken that away. So yeah, and then the anger and frustration. No control, no autonomy, and they do not want to change. So we don't have paper and stuff like that. But we did kind of touch on this initially, so I'm just going to put it out there. How would you describe with adjectives your practice under normal, non-stressed conditions? What is your practice like? What is your style? What adjectives would you use to describe?
Caring.
Caring, yep. Anything else? Supportive. Supportive, yep. Anything else? Calm, confident, organized, know what to expect. Things proceed in an orderly manner, according to the protocol. No problems, right? Now we're going to flip it to, stressful conditions. What is your practice like when you're under stress? when things don't go according to plan, when there's active rebellion in that bed in front of you.
Frustrations.
Yeah,
Rushed.
yep.
What happens to your approach maybe?
Shortens. You get shorter,
Oh,
more.
okay.
More abrupt.
Yeah, more abrupt.
Maybe less patient.
Yeah.
Lack of confidence with approach.
Yeah.
Is the right thing to say, do?
Yeah.
Yeah, and how can I get this done and get out of here?
I wonder if you tend to spend less time with the patient because you're so nervous about what to say, the right thing
Yeah.
to say versus the wrong thing to say, and you just don't have that internal confidence. So
Yes, that's right.
You just don't care anymore.
That's right, and we've all come up with
Yeah, let them.
It's like, okay, you don't wanna.
Our coping mechanism, yeah.
See, you mentioned you just don't feel like you care.
Like,
right?
why should you put more effort in, right? That's kind of.
Yeah.
Yeah.
So evoking strong emotions, right? And the stronger the emotion, the less your brain is on top of things. So you tend to rush, you tend not to be as organized. You may miss stuff, and definitely it will do nothing to foster a therapeutic rapport. So when you have such challenging clients, it's really helpful if you can practice some self-awareness and do things that help you to take a step back and manage your own emotions so that you can remember that actually you do have a lot of skills, you have a protocol, and you have an approach. Make sense? Yeah, been there. Okay, so in emotion-focused family therapy, we kind of talk about different emotional styles of caregiving under stress, right? So, and they use animals to depict these. So if you look in the 4 quadrants, the top one is having to do with high expressed emotion. So these are people that are just, you know what they're feeling because they let you know in no uncertain terms. So the one on the right is what we would call the helicopter parent. Too much emotion and too much involvement. So this is the parent that hovers around the bed and they're fluffing pillows and they're asking too many questions and they're kind of anxious, right? The other one is the jellyfish, is too much emotion and I'm going to go for coffee, right? So they don't have enough involvement and they're very anxious too. In the bottom quadrant, we have low expressed emotion. So these are the people who tend to be in their heads a lot. So the rhino is sort of like the bull in the china shop. They don't express much emotion, but boy, do they take charge whether you want them to or not. So they just come in and they do stuff and they tell you what to do and they point fingers and you're going to do this and you're going to eat, right? Without any kind of empathy or caring. And then there's the ostrich with the head in the sand. Okay, I'll come and visit later. And then they don't show up. Because, and in all cases, it's because they're overwhelmed and they simply don't know what to do, right? As caregivers, we want to aim for just the right balance of emotional involvement and control. Because our kids or our family members have a very serious illness and very little insight. And even if they do have insight, they do not want to change. So we do have to take some measure of control in helping them recover, but also be empathetic and understanding so that they trust us and are willing to take that first bite with us. So for you guys as caregivers in the hospital, you don't have the history of knowing this person for a long time, and you're only at the bedside for very short periods of time. So we want to make the most of that time, give an empathetic response, give measured caring and control, to make it easier for the client to eat and take medications and stuff like that. So the dolphin and the St. Bernard are in the middle. The dolphin is the intuitive, sensitive one, gives gentle nudging to guide the patient out of danger and towards safety and recovery. Whereas the St. Bernard is patient and caring, watches for and listens for that cry of help and offers help when needed. They don't barge in like the rhino. So we use this in teaching parents about different styles of caring so that they can identify which ones they tend to be most like, and then we can show them how to change to be more like the dolphin and the St. Bernard. That's the idea. So what is the therapeutic alliance and why do we bother? Because if you don't have it, your level of compliance with the patient will be way less than the optimal and way less than the potential. It's a therapeutic relationship between the patient and you guys. When it's there, you know it because there's just a feeling, there's a bond that you can feel, and there's a sense of trust that the clinician has enough intuition and clinical judgment to guide the patient towards their goals that will be beneficial for them. Remember, food is medicine. It's all about the food. Even though the underlying issues may not be about the food, treatment in the hospital and in our program starts with food. So how can we accomplish that? And if you take a little bit of time up front to try to establish that bond, things will be easier. Because I hear that all the time from clients who've been in hospital. They go, yeah, no, the social worker, yeah, no, didn't like her, but there was this nurse, and she was amazing. And I trusted her, and I was able to open up to her, and she was able to get me to eat like nobody else. So it's worth it if you can hone that skill a bit. So how do you do that? So through the things that you say, through your body language, through your eye contact, you send the message that I hear you, I see you, I get you, and we're going to go on this journey together. You're not alone. So it involves acceptance, compassion, and of course collaboration. So then you need to balance that with non-negotiables, right, with boundaries. So what are non-negotiables? I mean, we have to have boundaries, right? No, you can't get up and pace the hospital corridor after eating for 2 hours. No, you can't get up and use the bathroom if you have a history of purging. These are mandatory treatment to ensure safety and manage risk, especially when there's medical instability and psychiatric instability too. So you want to stay calm, you want to maintain those boundaries, you offer choice whenever possible so that they have a little bit of control. And you know, you want to be friendly, but keeping in mind that you're not friends, you're a professional, and you want to be empathetic, not a best friend. Okay? And in a few minutes, we'll get into those emotion coaching skills. So examples of non-negotiables. Obviously, you can't be in bed and not eat at all. If you have low blood sugar and you're refusing treatment. Exercising or walking when bed rest is prescribed. And there's all those things about orthostatic blood pressure, hypovolemia, postural tachycardia, all that stuff. And then if there's involuntary status, if the eating disorder seriously interferes with decisions to consent to treatment, and but all of that should take place before they even get to your ward, right? Unless they try to leave against medical advice and they are physically and psychiatrically at risk, then that's when you call the doctor and get that. Are they still calling it pink forms?
Yeah.
Yeah, you get the pink form done and then you get somebody else to do the second one. So in working with non-negotiables, remember these people are highly, highly anxious. They're in their reptilian brain of reactivity. They're fighting, and their eating disorder self feels like they're fighting for their life. So they won't be rational. You can't really reason with them. They're totally rigid. And so the way to work with that is to give them a lot of warning, as much warning as to when things are going to happen. You provide a clear rationale, and you may have to repeat it because remember, their brains aren't working. They're not online, and if they've been in starvation for quite a while, their brain is actually shrunk. So clear, not too many words, rationale, and with empathy and support. So you aim to maximize autonomy and collaborate on decisions, because if it just comes out of the blue that they're having an NG tube, you can expect to be prying them off the ceiling, right? And we don't want that. It's very traumatic for these people to be in hospital at all, and we want to minimize that by taking a little bit of extra time. I know how busy you are, but if you can take a little bit of time just to connect and communicate compassion, things could go a lot better for them and for you as a result. So we're talking about the fight or flight aspect of reactivity when somebody feels like they're under threat. And anybody with a severe eating disorder in hospital feels under threat 24/7. So emotions automatically alter brain chemistry, right? And all of a sudden your thinking, problem-solving brain is no longer communicating with the rest of your body, because your emotion brain, the fight or flight part in the amygdala, has hijacked everything. Your brain is flooded with stress hormones, and so you get ready to fight or run like hell. And that's where they're at. So you need to be very calm, you need to speak slowly, you need to really be very present with them in order for them to calm down a little bit. Okay, you want to take over now?
That's great. The other thing to keep in mind with this experience is that people with eating disorders are so used to being able to use those behaviors to help them cope with their feelings. And so now they're having all these uncomfortable feelings, super high anxiety perhaps, and they can't go for a run. They can't run to the washroom, get rid of the food, right? They can't do those behaviors. So it's really, really difficult.